Today I will be discussing patient selection criteria for deep brain stimulation surgery in movement disorders. My name is Dr. Lan Lowell, and I'm a junior faculty in the Department of Neurology at Beth Israel Deaconess Medical Center at Harvard Medical School in Boston. The objectives of this talk include appreciating the 3 indications for DBS in movement disorders, appreciation of the patient selection process for DBS in Parkinson's disease, appreciation for the 2 targets commonly used for DBS in Parkinson's disease, understanding the role of palatal DBS surgery in primary dystonia and certain types of secondary dystonia, and finally to understand the role of thalamic DBS surgery for essential tremor. The FDA-approved indications for deep brain stimulation surgery in movement disorders include Parkinson's disease, which is characterized by the 4 cardinal motor features, including rest tremor, bradykinesia or akinesia, rigidity, and postural instability. Essential tremor is another FDA-approved indication for DBS, and that is a postural or kinetic tremor affecting mainly the arms and the hands, but sometimes also including the head, jaw, and voice. And finally, the other indication for DBS is dystonia, which is a sustained involuntary muscle contraction generating twisting and repetitive movements or abnormal postures. Patient selection criteria for DBS surgery in Parkinson's disease is one of the crucial parts of the DBS process. The patient must be diagnosed with moderate to early advanced idiopathic Parkinson's disease and not have any features that point towards atypical Parkinsonism. They must have disease for at least 4 to 5 years, demonstrate improvement in motor symptoms after levodopa intake, must not be demented, understand that DBS surgery does not cure Parkinson's disease, and have realistic expectations about what DBS surgery can and cannot improve. Pre-surgical evaluation for DBS in Parkinson's disease include obtaining a detailed neurological history, making sure that the patient does not have features which point towards atypical Parkinsonism, a detailed neurological examination done by the neurologist or the movement disorder specialist, a neurosurgical evaluation, neuropsychological testing, neuroimaging, preferably MRI of the brain, medical clearance for surgery, and psychiatric clearance if needed in globus pallidus interna and the thalamic nucleus are 2 targets used in Parkinson's disease. Both targets can improve the cardinal motor features in Parkinson's disease, including tremor, rigidity, and bradykinesia. Both targets can improve levodopa-induced dyskinesias and motor fluctuations. Dopaminergic medications are more likely to be reduced after subthalamic nucleus DBS than with globus pallidus interna DBS. Globus pallidus interna deep brain stimulation surgery for primary and certain cases of secondary dystonia. The best DBS candidates are those with medication refractory primary generalized dystonia, or in certain cases of secondary, for example, tardive dystonia. Younger patients with primary dystonia improve better and faster after DBS surgery. Psychiatric comorbid conditions should be addressed before surgery. And again, patients should have realistic expectations about what DBS can and cannot improve. They should be warned that results or improvement in their dystonia may vary and can take months to achieve. The ventral intermediate nucleus of the thalamus, VIM-DBS, in essential tremor. The best DBS candidates are those with disabling medication refractory tremor. The most commonly used target is ventral intermediate nucleus of the thalamus. The caudal zona incerta DBS, CZI DBS, can be used as well. Tremors of the head or voice often have inconsistent benefit after surgery. Patients, again, should have realistic expectations about VIM-DBS for their tremor control. They should be cautioned that DBS does not improve speech, balance, or incoordination.